I'm Danielle Huston. I'm a health and welfare advisor here at Lockton Companies in the Pacific Northwest. I'm also the MC for our time together with Nice Healthcare today. But this is a collaborative effort to bring the content together, and especially in building what is a really special partnership with Nice Healthcare. It takes a team. My colleagues in Denver especially have run point on this for more than a year. They have been analyzing from a variety of ways and developing a partnership with Nice Healthcare. I get the pleasure of being the voice of this today because we decided there's a little bit of a common thread here. Lockton has recently expanded their presence here in the Pacific Northwest by opening up an office, and Nice Healthcare has also expanded their delivery of direct primary care here in Washington recently. And we thought, well, wouldn't it be nice for all of us who are working in new markets to do something special like this together? So here we are. But make no mistake, I have colleagues from Denver and from Arizona and here in Washington who have helped pull this together. And in fact, you may have been invited by one of them. And so on behalf of all of us, welcome to today. And we really look forward to introducing you to what we might call a little bit of a disruptive healthcare provider, and not disruptive in a bad way, but more like an introduction back home to what healthcare was originally intended to do. So joining me today is Eric Hirschberg. He is also one of my Lockton colleagues. He's in Denver. He's been with us for more than 20 years, leading our consulting practice out of Denver for our Mountain West series. And he has really taken ownership of developing this relationship with NICE. He's going to speak to the data. We know that measurable is really important. So he's going to lend a very unique perspective there. And he's long been an advocate and a thought leader around direct primary care. So I always enjoy listening to Eric's experience and his perspective there. Also joining us from Nice Healthcare is John Young. He is the Senior Vice President of Growth at Nice. His background, and I'm just going to refer back to my notes so that I don't leave anything important out, but his background comes from leading several commercialization teams within the medical device industry with a focus on technologies and services in remote monitoring and diagnostic space. His growth team at NICE is now focused in expanding into a number of different and new geographies. Under his leadership, NICE has expanded into 9 states and serves over 40,000 members on their platform. Also joining us is Elizabeth Chidothe. She is a registered family practice nurse practitioner. She received her master's at the University of Pennsylvania. She is also the clinical manager at NICE. She is on the medical advisory board. Her work as a nurse practitioner has included being at a federally qualified health center, serving the underserved at the retail health space, and finally here with NICE Healthcare, providing direct primary care. So welcome, and welcome to Washington, you guys.
Thank you.
So great to be on this call, Danielle. Thanks for having us.
Well, and thank you for coming. And again, there might be people on our call today who are from Denver or who are from Arizona. The invitation was extended to many, but as far as your entry into Washington State, that's especially exciting for us here in the Pacific Northwest. So John, will you get us started with giving us a little bit of background on who NICE Healthcare is?
Of course. And I think let's take a step back. I mean, since 2017, NICE has really been at the forefront of a new care delivery model that combines in-home visits with virtual visits. And the fact is that our leadership team has actually been working on this opportunity for over 10 years in different capacities. So like most good entrepreneurial stories, NICE started based on personal experience that we had when accessing primary care for our own families. And throughout that pursuit, we came to a conclusion. We came to a conclusion that the healthcare system at best is inconvenient for most people, and at worst is unaffordable and ineffective. So a series of trips back and forth to the doctor's office in the harsh Minnesota winter, where I'm dialing in from today, we came to the realization that there's nothing special about the clinic itself. And all of the value is really wrapped up in the clinician. So when you combine that with the incredible advances in technology, the tools at the disposal of physicians with things like mobile imaging, mobile phlebotomy, other remote monitoring diagnostics, it really became clear that it's possible to maintain a relationship between a patient and a care provider while removing barriers that exist to traveling into a clinic, whether those barriers are financial barriers or simply the inconvenience associated with it. So we started a clinic, we called it NICE, and rather than following in the mold of traditional primary care structures, we made three big decisions that are foundational to how we operate. We don't operate any bricks and mortar clinic locations. We use a combination of in-home visits and telehealth to reach our members. The second thing is that we don't submit any claims through an insurance vehicle. Instead, we charge a fixed monthly rate for unlimited access to our services that we're going to talk about today. So we operate much more akin to a direct primary care clinic. And third, we made the decision to be a nurse practitioner-led clinic. So we have a team of NPs who are full-time W-2 employees of ours, made a conscious decision to come and practice care under this model because it allows them to get back to what got them interested in this profession to begin with, which is developing long-term meaningful relationships with their patients. So those are the three kind of key decisions that set us up for success today and continue to grow into new services and to grow our footprint and grow our team and so forth. And so we're happy to be here talking with future colleagues in Washington and across the map.
And that's really the heart of direct primary care, right? It's this idea that we don't have to schedule an appointment, walk into a brick and mortar clinic and present with our one complaint, our one condition for a 15-minute visit with a provider. We're talking about having access to as much care as you need when you need it, ultimately. So I think let's go ahead and kick it over to Elizabeth and ask, from your perspective as a clinician, what does it mean to practice healthcare under this direct primary care model?
Thank you, Danielle. I feel like both you and John have hit it on the head, and that is time and access, not only for the patient, but also for the clinician. So in my experience as a nurse practitioner in the federally qualified health center and in the retail clinic setting, patients would oftentimes come to me and have to wait in the lobby for half an hour or an hour. They would need to, like you said, have only 15 minutes with me. That's fine when you come in for a simple sore throat, but when people come in with a list of concerns, not only about chronic conditions, but also social conditions, social factors that are playing into those conditions, I had 15 minutes or actually even less to hear them, to come up with a diagnosis, and to treat them. And mind you, this doesn't include education about medications or anything else that we are providing at the time. Excuse me. So for a patient's perspective, I always say too, with NICE Healthcare, with the direct patient care model, there's no waiting. You make that appointment at the time, and then when the patient, or when it's time for your visit, you show up. So that means you continue your lifestyle. That is, if you are a busy professional and you are needing to slip in this visit during your lunch break, during a 15-minute break during your time, at work, you can do that. If you're a busy mom with 3 children and one of your children gets sick and you don't want to haul everybody to the clinic because nap times are coming up, you can be at home with your child and make that visit and wait your turn for the clinician to come on video when it is time. And or if you're sick, you're just simply sick, and you really don't want to go into the clinic. Again, we start that visit virtually, and then we're able to come into your home or your workplace or wherever else that you are. And so the convenience of that, the access that you're able to gain, makes it better for everybody. With it going away from fee-for-service to direct patient care, we get rid of the need to have so many 15 or to 30 patients in a day. So we have time, like I said, time. So I have 40 minutes for a virtual visit with our patients, and then an hour for a home visit. So per condition, I have up to an hour and a half that I can spend time with you. That means to listen. That means to educate. That means to diagnose in a full way. And that leads also to cost savings, because we include so many things in this membership fee. That allows me to take the time to diagnose you. It means that I can prescribe to you over 550 medications that are covered. It means that I can send someone to your home for an EKG and get interpretation same day. That means that I can refer you to physical therapy and or mental therapy. That all is included with Nice Healthcare fee without you leaving home. And so I just really feel like we are able to wrap a full service primary care around you at the convenience for the patient and for the provider.
It's one of the things I really like about your model, because often when I think of direct primary care, I think of, someone either maybe coming to my home, or I go into maybe, a clinic that is just specifically yours, but maybe there's, a longer window of time. We have some of those in Washington. But the part that I really stop and have to open my mind to consider is that it isn't just having the ability to come into your home. It's the ability to start with a telehealth visit, which so many more of us are going to be familiar with after the last year and a half. COVID really pushed that forward, right? So that should feel kind of normal now to have that kind of a start to a visit. But then if I need to, you can come to me. And when you come to me, it doesn't have to just be the direct primary care. I think it's incredible that we're talking about physical therapy that can be done virtually, or mental health care that can be layered on top of what might be included in our core health plan, but available to me at no, or maybe a very low cost if I have a high deductible plan. So we're talking about care that starts to feel very robust. And that was one of the things as we were developing content for today, is that really is what makes Nice special, because it doesn't just end with the telehealth visit where you say, okay, there isn't anything else I can do for you today over video or the phone. Now you need to go be seen somewhere else. You can continue that portion of the visit.
Yes.
And that's pretty incredible.
Yes, it is. And I would say too, for being able to provide holistic care, I always feel like that's what really differentiates nurse practitioners and PAs from our colleagues, is that we learn how to see the patient as a whole before we learn how to diagnose. And so when we are able to get into these intimate settings of virtual care and in the home, we're not only just seeing the illness, we're seeing the whole picture of the individual, and able to tap the resources that we have to provide you truly primary preventative care.
So let's shift gears just a little bit to talking a little bit more about the model. And John, you and I have talked a lot about what makes the model itself look different than some of the others out there. Everybody's approach is a little bit different. What is the NICE approach toward business that makes it unique?
Yeah, I mean, I think, Danielle, it starts with the composition of the team that we've assembled, and the fact that the entire company resembles the diversity of the population that we strive to serve. So from ethnicity to gender to the experiences that we come from, it's an incredibly diverse team from the executive level all the way throughout the organization. We see diversity as an incredible strength of ours. We've adopted policies around hiring and pay that have instituted a livable wage, where our lowest employee at the company makes $65,000 a year, because we feel like it's the right thing to do, and it's going to allow them to lead a happier life while being more satisfied with their job. So we do things that set the tone of the clinic and set the culture across our organization that's unique, that allows us to attract awesome people to the model, attract an awesome clinical team with people like Elizabeth and her entire team of clinicians, so that when we enter into a market, we're drawing from the best, and that we're able to put together an attractive, package to bring someone over. And then once they understand what it allows in terms of that relationship to develop with a patient under a DPC model as opposed to fee for service, like that's our winning recipe. I think what also makes it special is that up to this point, access to direct primary care has been mostly unattainable for the majority of the population because it's so expensive. People are intuitively drawn to this model where they can go in and they can talk to Elizabeth without the constraints of fee for service and a visit being reduced down to CPT codes. Like, that's attractive, but historically that comes at a cost of $80 to $100 per member. And we have figured out a way to deliver DPC to the entire family for a capitated rate at $36 PEPM. That includes access for the employee and everyone who lives in that household. So now what makes it even more attainable is that we have employers that are looking for benefits and solutions that are comprehensive, they're easy to implement, and that can have a meaningful impact on their employees. And NICE checks all those boxes. We started this company as a solution for small and medium-sized businesses. And often innovation skips over that segment, and it certainly doesn't begin there. And so by integrating all of these components of primary care, and now including more specialty services like the mental health and the musculoskeletal care, pharmacy, we've created an easy to implement solution for employers, which is really important. And then you talked about like the last piece, I think, which is timing. Like, so much about innovation and new business models like this requires smart people, it requires luck, and it requires timing. And you talked about how virtual visits and telehealth are now more normalized, and every healthcare system in the country is trying to figure out how to incorporate it into their flow. And it's not because they necessarily want to or because it makes sense with their business model. It's because consumers are now demanding it. And telehealth is a tool that is baked into our DNA. But that real inflection point is when you have that virtual visit that ends in the conclusion that you need to be seen. And there's a good chance that most people on this call have had that experience now, and they understand that letdown that's involved when that telehealth visit results in that conclusion. That's what we've solved for. That's where we kick it into high gear and send a clinician out into Bellevue or Redmond or wherever it is within a certain geography that we're operating in.
I want to hover for a moment back around some of the comments around the kinds of businesses that are really the businesses where you are meeting them. And you've talked a lot about this, meeting the market where they are, being optimized for small and medium-sized businesses. Most of, what you're talking about, the direct primary care, has been reserved for really large organizations who could afford to build a clinic, even if they're building it maybe with another company or they're doing something freestanding. But that's not hardly ever in the budget for a small or a medium size business. So if you can, just really quickly again, I mean, I know you've talked about the $36 per employee per month being that capitated fee for nice healthcare. In comparison, what kind of an investment does an organization have to be able to make to have something like a near site clinic or other avenues of direct primary care?
I mean, Eric, I would also invite Eric to comment on this too, because on-site clinics I think they do have a valid place with a certain profile of an organization, or, like they're large enough. I come from Medtronic. We had an on-site clinic and it worked for that type of environment, but they had the cash to invest in that, and they could have a clinician sitting there, throughout the day. I think one of the really interesting things about what we've learned is when you put an innovation out there like this, it's interesting to see how individuals or companies will leverage it. We've started now working with employers who look at NICE as a way to establish an on-site clinic opportunity for patients to be seen. If we have an employer that wants to dedicate space for patients to be able to have a visit, privacy, without having to take PTO, without having to leave work, we'll send a clinician on site. And in that scenario, there's really no investment that's needed in terms of building out a clinic location for a given employer. But I'd be curious to get Eric's thoughts on kind of that decision-making process when you have groups that are on the verge of thinking about on-site clinic or near-site clinic.
Thanks, John. Yeah, I'll be very brief. Lockton has numerous large clients that have on-site clinic capabilities, but it's a big engineering undertaking. It can be very expensive. Hey, the dividends are wonderful, but it's a big commitment. What you've done is brought this down to the middle of the small market, made it abundantly easy for clients who aren't large and don't have the financial wherewithal to build a clinic, but basically offer, as you said, an on-site clinic alternative that, frankly, I think is even better than an on-site clinic, because the folks at on-site clinics won't get in a car and come to your house or to your workspace and examine you there. And what you do is unique. So Danielle, I'm glad you brought this up, because this is a platform that is applicable across all industries, all size clients. And it's NICE Healthcare is not the only one in this space, but they have built this platform and priced it at a point that nobody in the industry can touch it right now. So John, I'll stop there and turn it back over to you, or Elizabeth.
And John, if I may, I actually failed to mention that I did work on an on-site clinic in Minnesota, UHG, for a little bit. So I was a nurse practitioner for a year. And during that time, one of the benefits, or I guess one of the pitfalls of their that model versus what I see is a benefit of NICE Healthcare, is that, again, our service fee covers the employee and their dependents. And so when someone is ill at work, they're at home. They're not going to come into work. Think about during COVID, we're not going to have you come into work to be tested or to receive care. You're going to want to stay home. So it was a really great model for the individual at work when they fell ill at work. It was also a great model for when they had chronic illnesses that needed to be worked on at work. However, for the rest of the population, for your dependents, for your family members, and for those who fell ill at work and wanted to go home and or were at home and didn't want to come to work, that model of the on-site did not fully function in the way that NICE Healthcare can actually meet the patient where they're at.
Meeting the patient where they're at for a price point we can't see anyone else touch, which leads me into something that I want to be really sure we talk about, because it's one of the things that I think is incredibly attractive, ethical margin. And I don't know if you guys coined that term, if you made it up yourselves, but I think that many of us would appreciate hearing, John, your perspective about ethical margin and what that means for your business practice.
Yeah, that's a good question. If Thompson coined the phrase, I wouldn't doubt it if he did. honestly, because and Thompson's our CEO and one of the co-founders of the business. His entire mission behind this thing is to make care as affordable and as convenient as humanly possible, full stop. And he also has in his back pocket that he has a master's degree in statistics, and he was a health economist, and he's worked for these plans. And so he's just a really a smart fellow, this Thompson guy. But he's instituted this kind of philosophy of ethical margin, which basically means that once we have set a price point that allows us to make enough money to pay our people well, to invest in the business, and to do everything that we want to do as an organization, then we pass along savings to our employer clients and to our patients, full stop. And so we've reached that point right now where we're able to generate enough money to do those things that we want to do. And now it's time for us to start passing that along to the employers who choose to offer us as a benefit, and to the employees and their families who ultimately end up wanting to use us. So that's the idea behind kind of creating and establishing this ethical margin, so that we can be along for the long run and we can be successful financially, but where we're not getting greedy.
So what I hear is that it's possible to deliver great quality healthcare and to do it while you make a profit, but not necessarily on the backs of everyone else, that there can be a great balance.
Right.
I'm rooting for you to demonstrate that, because I think that's a great challenge to many in the healthcare space.
Yeah, and luckily we have enough employers who have believed in us to give it a shot, because a lot of the times we'll get the reaction of it sounds too good to be true, or are you guys going to be around? Now we have 300 employers on the platform, we have 40,000 members, but the real proof is in what is the customer and patient experience on the other side of that, right? And so the main way that we measure our success as a clinic is looking at that Net Promoter Score and making sure that our patients are happy and that we're doing what we say we're going to do for them, and that we're able to deliver on an awesome experience while generating this revenue that we're talking about. So it's operating efficiently and it's operating well.
Well, I think when we're talking about healthcare transformation, and I think that's one of the things we're really talking about today, is that transformation, that it really should do two things, right? I'm sorry, my dog is so excited to see me. He acts like he's never seen me before sometimes. Hello. So if we're talking about transformation, should offer measurable results and impact real humans. And I would love to talk about the humans. So Elizabeth, as a clinician, are you able to build those client relationships in this model? Is it hard to deliver care over video or chat? What is that experience like for you, but also for the people that you treat?
So I'm excited to speak to this. So I feel like when you connect with one of our providers, either virtually or in person, that is such an intimate space that you actually build connection and community immediately. Also, we are hiring nurse practitioners on the ground who come to your home from your region. So oftentimes they are the person down the road. They are the person that you may run into at the marketplace or elsewhere in your community. So it is a local provider. I want to print some pictures of some patient experiences that I feel have been impactful. We have many that lead to that NPS score of greater than 90%, essentially since we've opened. But these are some really great ones that not only highlight the community, the relationship building, but also the cost savings and essentially all the aspects of nice healthcare. There was a young man who came for management of his high blood pressure. In fact, he came through chat and said, "Hey, I just need a refill on my meds. Like, this is my history with this. Great, show up when you need to." We needed a home visit because we need to draw some base labs for people who have high blood pressure, and we need to measure their blood pressure, listen to their heart and lungs and such. And so our provider showed up and noticed that he could utilize he had some other medications and could utilize some other services. and said, hey, I noticed you haven't had a full physical in a while. You've just been receiving these medications. Can we set that up? Well, he's immediately felt that bond with that provider and said, yeah, let's go ahead and do that. You've met me where I'm at. I'll move forward. Moved forward. And in the progression of his care with us, he had 9 encounters, 2 of which were in person. The other were either virtual and or chat. He ended up, through the assessments of my providers and the ability to connect to him and be able to effectively guide him through some changes, he lost 100 pounds. He was able to get off of his diabetic medication. He was able to reduce the amount of high blood pressure medication he was on. And he had been taking a controlled substance for anxiety, and we do not prescribe controlled substances. And he was able to get off of his anxiety medication, enter our mental health services, and be able to control his anxiety. He actually had better control of his anxiety through alternative forms of control for his anxiety. Huge success story, huge on multitudes of levels. And so, and that comes from the relationship and the access and the time that was granted to him. Another similar story, but more on an acute level, was a young single mom who had a rash, had presented to us twice virtually, ended up having some systemic symptoms, meaning that it had traveled to elsewhere in her body. And therefore we decided we needed a home visit. This person ended up having 7 encounters with us, 3 virtual visits, 1 home visit for the physical assessment, and ended up having multiple blood draws. And we were able to, that individual was able to receive an antibiotic, a steroid, and most of the blood. There was a few outliers that she ended up having to pay close to $200 for the total, but that was 7 encounters for a pretty severe form of illness, only for $200, and the savings obviously for her was elsewhere for that. And then the last more common story is, again, that this is not specific to one, this is many, is the parent who is at home with an ill child, not wanting to bring their child in for strep. They have 2 other kids that are home, either nap time or whatever, what have you, and they just don't want to bring that child in. We're able to virtually assess whether or not a strep test is needed, send that provider to your home to swab the child, and be able to provide that medication at no cost to you. So the amount of, an example like that, one of the providers was leaving the home, and one of the children said, "Thank you, doctor. I want to be just like you when I grow up." And that just highlights the relationships that we have. And not only that, I want to also point out to the quality of the care that we provide. Because we have only see a few amount of patients per day because of the because we have so much time, we also institute things like a lot of continuing education, personal and professional development with our providers. We have lead providers who don't even see patients, that are there readily available for our providers to act as a resource, who are looking up up-to-date information, who are providing guidance to our providers on the ground when they have questions. So we are providing evidence-based care on a regular basis. We also make sure that we do things like we do an M&M, which is a morbidity and mortality conference. This is just a fancy word of saying that we take difficult cases and we come together as a team to look through them and make sure that we are developing really strong scientific approach to our patients. And the team feels extremely fulfilled by that. And we love to provide care. So not only are we providing great care, but compassionate care. And lastly, I'm going to say that, and just speaking of our app, the relationship can be built unlike a lot of the other ones in terms of access to the same provider. So when you go onto our app and you make an appointment, you can select the provider. So you can choose to have a relationship with one individual, or actually usually two individuals, a video visit provider and a home visit provider, consistently, so that you are not having to get jungled through a system.
So what I'm hearing is, in addition to that low per employee per month cost for the patient who receives care, there's little to no cost. And I think at the end too, we'll talk about high deductible health plans, how that can factor in here. But for so many people, you pay your cost share to have your health insurance coverage. And then, if you do have a situation like some of the examples that you've talked about, where you end up in an emergency room and you have maybe 6 follow-up visits, not only did you meet probably your $1,500 to $2,000 deductible from the moment you walked in to the emergency room, but throughout the course of your care and getting some prescriptions, you might be pretty close to your out-of-pocket maximum. All of a sudden, you've had a really expensive encounter and you didn't maybe even have surgery or have some catastrophic accident.
Yes, and that's pointing to that rash patient where, again, that individual likely would have in a normal typical setting at least would have spent at least $2,000 minimum.
Yes. And those claims were not incurred on their employer's health plan either.
Correct.
So,
yeah. And then with the anxiety that may come up around having an unfortunate rash or systemic symptoms like that, that individual, those were 7 encounters. You can follow up and have access to our providers via chat anytime during our open hours, just to say, hey, how are you doing? I'm doing better. How's your anxiety around that? Oh, I'm okay. I'm feeling okay now. So we care about you, and we're there. We're holding your hand. I think you've done another interview recently where I saw on LinkedIn where someone said, I felt like I was followed or I was kind of carried through my illness. And that's exactly what we do. We hold your hand through illnesses if that is what you need at that time.
Trying to mute here because my dog again is barking. I think there are just so many compelling stories around, people's experience with the healthcare system where they spend a lot to receive the care and then they don't feel like they had adequate care. They didn't feel like people listened to them, and being able to bridge all of those things together, I would think even as a practitioner would make it feel a lot like what you envisioned when you decided to choose the medical field as your industry and not 15-minute fee-for-service visits.
Yes, I think you could Google quite a few articles on provider burnout in the current setting. So I don't need to speak too much about that, but that is a real thing and it's felt by most, and it's shocking. So we are not only providing this care for our patients, but we are practicing care how we intended it to be practiced.
It's a beautiful thing. So let's talk about the measurable results. And I'm going to start by saying there was a Milliman study that suggested that 12.5% of claims spend could be avoided if direct primary care was done right. So, John, I want you first to tee up for us why employers buy this. And then Eric is going to, really come in here and talk about the actuarial side and the data to support that. But you've got a really great story of measurable results and what a client expected.
Yeah. And I'll start with your question on why I think employers buy this. Because there's usually 2 main components. One is that they see it as a way to attract and retain awesome people. And 2, they see it as a way and a solution to help control healthcare costs for the organization and for the employee. So when we get into that quantitative discussion about the impact that something like this has, we start talking about our average utilization. And we do 16 visits per month for every 100 employees, or 192 visits over the course of the year. And we help our employer groups start to quantify what removing that volume of activity off of their insurance plan and underneath this capitated rate will do to the financials. it's a cost avoidance calculation. It kills Thompson because that's not even really getting into ROI, right? Like he wants a p-value of 0.05 on our ROI calculation before we start really going out there with it. But it gets us that conversation with the CFO for him or her to understand that, yeah, there is a quantitative argument to be made to put this in place. But that's not always the primary reason why they buy. There was the story I wanted to tell was that there's a meeting with the CEO of an environmental company out in Colorado, in Denver. We went through the Fort Collins. We went through the whole thing, talked about it. And he says, look, John, I get how shifting utilization from other venues of service over to this is going to help us save money. Like I understand that. He said, I like this for two reasons. One is that I'm tired of seeing healthcare companies build big fancy glass buildings while my health premiums go up. So anyone who comes in and wants to help disrupt that, I want to get behind. And two, he said, we as a leadership team can learn from working with young and innovative companies like yours because you guys bring a different approach to business and our employees pick up on it when we offer them benefits like this that are new, innovative, and it's something that they want to have be part of their benefits package. And I sat back and I almost started to like tear up because I'm like, this is the profile of the employer who is going to be a good fit for us and a good customer. They understand the premise behind shifting care out of more expensive sites of service. They get behind that. They know we're going to drive utilization, but it also sets a different tone in terms of the type of benefit that's part of their package and they want to get behind it. So that to me is like the perfect roundtable discussion where I can leave feeling good about it.
And then you can double up with, a lot of the work that Eric and his team has done around the analytics. And Eric, I'll let you really chime in there because I know that not only have you led that work, but your experience in that space we can all learn from.
Well, thanks, Danielle. And I know we haven't got a lot of time, so I will be very brief. Let me provide an editorial up front, though. I mean, the primary care delivery system, the traditional fee-for-service primary care delivery system is a wreck in the U.S. We know that it needs to be recharged, if not fully reinvented. So the reason we're here today is because direct primary care presents tremendous and really creative opportunities for companies to think through how they're delivering health benefits to their people. Direct primary care has been around. NICE isn't the first company to try and take a whack at this, but what they've come up with is in our view at Lockton, exponentially more interesting and better than some of the models that have been around. So that's why we're here today. I want people to understand this platform of theirs sits on top of the existing health benefit plan of the employer. So the employer's not getting rid of the core medical plan. That stays in place, that sits on top of it. And the whole economic premise, as John just shared, is that we're, with this in place, we can redirect claim costs that would otherwise accrue under the core health benefit plan to the folks who are delivering care at NICE Healthcare. It's now NICE Healthcare's problem, these costs. And at $36 per employee per month, they have solved this problem. They're able to provide this wide range of services, preventive and chronic condition and imaging and mental health at $36. It could be because of their ethical business model. I think it's because they're really smart business people and they're not using physicians to deliver services. So yes, does Lockton support this? We do. Is it a fit for every client? No. Is it a substitute for a health plan? Not at all. But it really complements what most of our clients are trying to do, which is to provide a reasonable benefit to attract a health benefit so they can attract and retain workers, which we know right now is virtually impossible to do. John, you did mention your net promoter score of 92. To me, that's more important than anything we're going to talk about today. The people, the companies that you've worked with and the surveying you've done with those companies are supporting that this platform delivers a net promoter satisfaction score of 92. I mean, that is off the charts. Nothing we can do in benefit planning with clients or for members in health plans is going to deliver a 92 NPS. So forget everything else, even if this thing didn't pay for itself. I mean, the value add here is unbelievable. The good news, though, is it pays for itself. And John mentioned it, and I'll stop pontificating here in just a second. But, you know, the Society of Actuaries said, we got to study this. There's a lot of talk. There's no foundation for any of the ROI calculations or for how much care can be redirected. So they hired Milliman, the smartest actuaries on the planet, to complete a study, which was done last year, that suggests, as John mentioned, about a 13% reduction in per employee per month health cost in companies that put this kind of a direct primary care platform in. It's not nice, it's just direct primary care in general. The ROI is bigger for the NICE platform because the NICE cost of business is so much lower, 36 PEPM. But for those of you who are numbers people, the typical cost of an employee health plan per employee per year is about $12,000 per employee per year. That's $1,000 a month. Okay, so 13% of that's about $130. We'll do some simple math here. So you're going to save Mr. or Mrs. Employer potentially $130 per employee per month. It'll only cost you $36 to do it. By my calculations, that's a pretty good return on investments. That's a 3 or 4 return, which is perfectly consistent with the Milliman study. So, you know, there are no free lunches in our world, and usually in benefits, there are none. This is a free lunch. I mean, so you can provide employees with an enhanced benefit that delivers a 92 net promoter score with a return on investment of 3 or 4 to 1. Danielle, that's why you wanted to have this discussion today, because this is easy. Now, it's not a fit for everybody, but if this discussion today has resonated with you, I would encourage any groups out there to send us some. We'll take some of your basic health plan data. We'll run some numbers for you. We can validate the economic return on investment here. And then more importantly, we just got to decide whether this is a practical fit for all sorts of other reasons. But I'm going to leave it at that, Danielle, and turn it back over to you. But thanks for giving me a few minutes to state my thoughts about this. I think, you know, I'm a pretty big proponent of direct primary care and NICE healthcare. So thank you.
Yes.
Well, can I just add one thing to that, Danielle? I mean, I think where this partnership starts to deliver real value for employers is that Lockton is in a very unique position to be able to take a tool like NICE and to apply it to a much larger data set and an understanding of what's going on with the broader healthcare picture within a given employer. You know, that's where this really starts to work well, is that we can focus on expanding our service and doing an awesome job and making patients happy. Lockton can run it through their engine. Their smart consultants can take a look at the impact it can have for an employer, figure out if it's a good fit, if it's not fit, and then ultimately make those recommendations. So, you know, Danielle, like after this call, most people would probably think you're just a professional podcast hoster or something like that. But there's that consultant angle is really where I'm most excited about this going forward, is that we can continue to do our thing as a clinic. We can provide some data points on what we're doing. And then the right partner out in the field takes that and helps apply it to a broader data set that then allows everyone to kind of measure success over the long run. So I appreciate all the work that you guys are doing in this regard.
And, you know, to that end, one of my very smart, amazing colleagues at Lockton may have invited you to this today, or they invited you to listen to this afterward. Please connect with them and ask them about this exercise of looking at ROI and using the data, as well as these other factors that Eric has talked about, to see, is this a good fit for you and your organization? Do we have questions in the chat that we need to go through here? Let's see. So I'll just go ahead and read it. Is the 13% reduction in health plan cost even more with NICE because pharmacy, PT, imaging, labs, and mental health is also included? Could it be more because some carriers have premium discounts if NICE is added? That's a great question. Who wants to take, Eric, do you want to take that?
Well, I'll take a stab at it, Danielle. Yes, there are some carriers with whom NICE Healthcare is working, and they, John or Elizabeth can speak more clearly around this, but there are some carriers that are recognizing this as a redirector of claim costs, and they're willing to subsidize the cost of NICE Healthcare, that $36 PEPM, because of that. So yes, there's an opportunity there depending on which carrier is administering your plan. I think the deal you've got in place now, John, is with Cigna, yes?
Yeah, we have a number of carrier deals in the different markets that we're operating in, but that's one of them.
And then as far as the 13% goes, Danielle, that's an average. So it's going to vary by company and by the uptake of NICE Healthcare by members. I think the average uptake, John and Elizabeth, is around 16% of members used during the course of a year. But, if we can drive uptake, that's going to make the number look better. Lower uptake may make the number not look so good. But 13% is a pretty good starting point. And then again, as I mentioned earlier, if you're interested, we'll ask you at Lockton, your Lockton team will ask you for some health plan claims data, and we can run this modeler for you, and we will come up with a number that's going to be pretty darn ironclad. And it should be around that 14%, give or take.
Okay. And let's talk about high deductible health plans. That might be another place for Eric to chime in too. But, I know that there are some folks who have joined us this morning who do have a high deductible health plan. And when that is the case, NICE Healthcare, in my opinion, starts to become a why wouldn't you do this? If you have a really high deductible in place where someone does have to meet a $1,500 or a $3,000 deductible before they can, have that sick office visit, having this addition of NICE Healthcare would be incredibly powerful and a way to make healthcare more affordable and accessible for the people that are on that high deductible health plan who really can't afford to be on it. But when that is the case, those patients don't have a zero copay for NICE Healthcare services. And that's because of the federal requirements around having the high deductible health plan and the tax-free savings vehicle. But what you have done is to establish fixed costs that are still considerably lower than your office visit would be, or even some telehealth visits. I'm on a high deductible health plan. My last telehealth visit was $45. So something like NICE Healthcare can create some real consistency and predictability with the costs and still low cost, but to have the zero cost shares attached to your services, you have to be on the more traditional PPO plan with, not HDHP compliant.
It's a fun topic, Danielle. It's one that we could probably do a whole hour on. But, I think a good indication of the fit between the two is that around 90% of our clients have a high deductible health plan, at least as an option. It might be a standalone HDHP, or it might be in combination with a more traditional style plan. But about 90% of our employer groups have an HDHP at least in place. So we've solved for that and kind of through some of those mechanisms that you've alluded to.
So there's
I'm going to just speak from a provider's perspective on this too, where I see this is that we start to use our health insurance kind of like auto insurance. You don't pay for your checkups of your health, or you pay for your health checkups of your car. You keep your auto insurance for more of those big ticket items or for catastrophic events. Similarly with a high deductible, and that to me is how health insurance should be utilized. Secondly, some people might say, well, I might go to a Minute Clinic for this. Again, some of the retail clinics, they have a purpose. I'm not trying to knock them. And a lot of their services they cover are things for viral type of illnesses. And so we know that that costs you $90 to get the diagnosis of something that's viral. And then you're going to pay at least $25 additionally in front of at the pharmacy at that local, whatever is connected to it, whether it be Target, Walmart, what have you. And then you're out $115. So again, Nice Healthcare solves that in that we cost that patient $0, and we just covered the cost of the over-the-counter medication that you would mostly cost. So again, $0 versus $115, and we came to you or came to your home.
Okay. The other question that has come through, and I'm not sure if the person is asking from the perspective of an employer or perhaps the perspective of a patient. So if they could maybe type in the chat there for me. But the question is, what are the objections that you hear? Maybe let's maybe start with objections you hear from patients, if you hear any.
I think one misnomer is that we're asking you to terminate a relationship with your current primary care provider. Like that does not have to happen in order for you to start engaging with our clinic. So like that might be an initial reaction in an open enrollment meeting is I'm happy with my PCP. Like, why would I ever use this? So we help that employee understand how there's several other access points to why it would make sense to leverage the Nice clinic. And then maybe over time, we become your primary care provider. Maybe over time you use, both clinics. But I think that's one kind of common, at least initial objection that we help employees walk through during that education process.
Yeah, that is interesting. It's not an objection I actually would have thought of because we know so many people don't have relationships with a primary care provider. Right. From an employer's perspective, what kinds of objections do you hear from them?
Eric, what do you hear? Eric will get the most genuine responses.
I think that the number one objection, Danielle, and it's not really an objection, it's just it's a hurdle, and it's bandwidth. The employers are juggling, HR departments, benefit leaders are juggling 14, 15, 18, 20 balls at a time. And it's a matter of priority. If your health plan is running really well and you're not having trouble attracting or retaining talent, this may be a short discussion. But if it's the opposite on both of those counts, this may get some bandwidth with a company. So again, as we've said many times, not a fit. Life is all about timing and circumstances. So, but this is a tactic that we must continue to have on our radar screen, because there will be a time and a place where this is going to be relevant, probably to everybody. The growth of direct primary care in the United States of America is going to be exponential over the next 5 to 10 years. And that's pretty easily demonstrated by the fact that one of your big companies in Seattle is, trying to put their stake in this ground. So watch out. But there will be a time and a place for this at some juncture for everyone.
Yes. And I am also, and Eric, this is probably going to be a place for you to contribute as well. But, when you talk about bandwidth for the employer who wants to launch direct primary care and engage in a relationship with Nice, and they're lacking some bandwidth, Lockton can help, at least with, some of those pieces like education tools and, our advice and counsel on what works really well and what doesn't work. We've done this a lot. We can help people figure out the right way to do it. Is there anything else that you would contribute to that?
Well, I think John would love to answer that question too, because they provide tremendous support and resource in that area. John?
Yeah, another co-founder of the business, Allison Santos, she leads up our entire client engagement function, where her sole focus and her team's sole focus is on driving engagement in utilization after an employer has made the decision to invest in this. And so, that often starts in an open enrollment, but it's a 12-month process, where we have consistent touch points throughout the year to make sure that employees understand how to leverage the benefit when it's appropriate to set up visits with us. access to other resources that they have through the benefit. So appreciate you teaming me up there, Eric, because the engagement piece is actually where I was going to answer the question on a potential objection, is that you have employers who have maybe put pure telehealth plays in place and they've seen low to no adoption of it. And so they might make the mistake of bucketing this as a telehealth play, which it's not. You know, we always set the reference point of this is a direct primary care clinic that uses telehealth as one mechanism for reaching the patients, but it's just one piece that's baked into the fabric of the organization. And once we help, you know, kind of put it in that context, we can overcome that objection of historically low utilization, because there's all sorts of reasons why telehealth adoption as a pure play might have limitations.
Thank you for that. We are at time. In fact, we're just a couple minutes over time. So thank you for folks that have stayed on and have listened and contributed some questions here to the chat. I'm just going to remind all of you that, you know, if you want to continue this conversation, please connect with your Lockton team. We are well situated to be able to walk through this with you and help you to decide if this is a right solution for you. And, you know, when it comes to this conversation with NICE, you know, I just want to say it again that, you know, to me, it feels like more of a return back to what was originally intended for healthcare: personal, relationship, compassionate, affordable. So if that sounds like something you'd like to learn more about, then we would certainly love to help you do that. Thank you for coming. Let's reimagine what healthcare could be together. Thank you for your time today. Take good care.